This is put a list on the table. And still, if there are too many procedures, a long list, then I do it because sometimes you can forget things. So it's always a good idea to make a stepwise plan. And as Gavin said initially, I always say, have a problem list, see the list, what you're going to follow, how you're going to tackle the problem, right? And the problem list is actually twofold. One is what problems the patient you can face, likely problems. And second, for the procedure itself, what can be likely problems? How are you going to tackle them? And what's your plan B? This is a usual we should always have. Or if you can stick it on the theater table, it's brilliant. So the most important thing is pre-planning. You have to pre-plan for a number of things. Pre-planning to understand where you're going to put your osteotomy, how well it's going to translate, will this take this implant? If you look at Paul's talk, if you look at it, he was planning the nail, but sometimes with the translation, it can be difficult. So you have to plan it and see, am I okay to ream one side of cortex by putting puller screws and this nail would be okay? Or do I need a different device? Will that device be biomechanically stable? Or what is the best biomechanical device? And how that best biomechanical device, which respects the biology, is suitable and how I can put that. So there are a number of things you need to pre-plan. And the simple thing is, if you have any software, TraumaCAD or Bone Ninja, plan on that, move your osteotomy up and down, see how much it moves, where it moves. If you don't have that, which I used to do when I didn't have TraumaCAD, print the X-ray on a piece of paper from PowerPoint. Take a pair of scissors and some sticky tape, cut at various places, move around and see what fits well. Actually, it works equally well. The only thing is it doesn't look very sexy because the colored lines and all that looks a bit tatty, tape sticking all around, but it does exactly the same job. And I still got pictures when I used to do that because our hospital will not buy TraumaCAD to us because it's a very expensive license. Now, this we talked about that constrained and unconstrained correction. If you're doing a constrained correction with hinge, then your hinge has to be absolutely spot on. And if you're unconstrained, then you have to manually move it. Now, the thing is that if you are doing a constrained correction, you should have a plan that if I put my hinge wrong, how else can I move it, right? And if you look at you got two rings and then two hinges, long rods, it's slightly unstable in a way. So either you use LRS, which is quite stable and that you're fine, and which you can loosen the pins and move it up and down, or what you can do is you should have a device, something to put an additional support bar after translating or moving so that it stays where it is. So you should have that plan or some backup with you in the system. Now, osteotomy rule becomes very, very critical, and that's the reason osteotomy rules are important, because rule 2 is often used. Because if you see, most of our deformities are infection, trauma to children, growth plate. And cora or apex of the deformity is very low, right? So post-trauma midshaft fractures are not as many. The more of the deformities are periarticular apex. And there you cannot do the osteotomy at the apex of the deformity because you will not have enough bone to fix it, to stabilize it. So you have to move it. Once you move it, you have to have obligatory translation, and that becomes quite difficult because unless we plan it, we cannot put the right implant. If you have a Unico, you do manual, and LRS actually that way works quite well. If you are good at LRS, I'm not very good at it, therefore I don't use it as often. But if you are good at LRS, you learn how to do it, then what you can do is translation becomes quite easy. You loosen I think we did it in one of the labs. You loosen the bolt and just move it up and down. And because LRS, the hinge is never at not always, but most of the times it's not at the apex of the deformity. So there's a translation, you have to correct it. So that's quite easy, and it's a quite strong and stable fixator. So if you're good at it, it's a very good, but there's a particular technique with it. The downside of LRS is you have to be good at it, because if you don't get it right, it's very little play because it's a very stiff construct. So you have to get it really spot on, and that way. Hexapods, I do not use it because I think it's an expensive way of doing things. There's a lot of other things you can say I use a lot of money, but hexapod I find is quite expensive and it comes in the way. And unless there is a very complex deformity, I don't think that is the normal use. There are a couple of units in UK who use it, particularly Bristol, who sort of propagated and brought the term chaos. And we'll talk about it in a little bit later. So this is an example just to say that how pre-planning is helpful. So this is a lady, about 72 or 73, and she's got some very significant valgus. Knee surgeons are not happy to do it because there are a lot of deformities, and they say, so they were sort of very hesitant, and they sent it to us saying that, can you do something about the leg so we can put a knee replacement? So what you do is you pre-plan it. Now, if you see, when you pre-plan it, I want to shift it axis and a slight translation at the femur and significant translation at the tibia. So we need to know, we know that how we're going to do it, what the plan is, how much is going to translate. So I use the Unico because you have more sort of easier with that. So that's the femur. And if you see that femur has translated as much as you want, there's the tibia. So we translated it, then put in a plate. And if you see the whole picture overall, the whole thing is translated and your axis comes quite straight as the medial tibial spine where it should be. Now, she's pain-free, like a lot of these patients are. How long, I don't know, but she's pain-free for about 4 or 5 years now. So hopefully she will outlive, but we don't know. So idea of this is not to get the is not the treatment for arthritis, but by correct alignment and putting the bones in the right place and the axis, what you will find is a lot of these patients become actually pain-free. As I said, device compatibility is very important. You need to mark and everything. It will be very difficult, and it looks really silly when your internal implant comes in the way of external or other way around. So you need to plan it, and you need to plan it in a way. If you're not happy, just do it on a sawbone. It's perfectly acceptable and quite good. Take the sawbone to the theater. A lot of pelvic surgeons do it in complex deformities. They in fact had a 3D printed model where they put it the fixation and then take it to theater. So you can do that. That's not a problem. The other thing I want to bring your attention is the rotation. Now, if you see, when you have the hip anterior and knee anterior X-ray in presence of rotation, right? Then what happens is that your neck length gets less. So actually the center of the head shifts. So it's quite simple. This is your length of the head, and if you have a retroversion, this distance will decrease. If you have anteversion, this distance will decrease. So that will affect how you, now it's not a big difference, but it can be subtle and it can be difficult. So let's take this example, which I showed in my previous talk. So this is an example. So if you look at the preoperative deformity, if you look at it, if I don't have the pictures, but if you rotate the head, it's anterior or retroversion, it will shift laterally, and which means if you take the center of the head, the amount of deformity is less. It will also affect postoperatively, because if you look at it, the deformity looks slightly undercorrected there, or they're slightly overcorrected there. And that is the effect of the rotation. So you need to be careful then. So what I would suggest is, thorough clinical examination is important. Do your rotational profile. Normally you will know, it's quite obvious, but if not, then a thorough clinical examination is very important to ensure there's no rotational deformity. And when you are checking your axis, make sure that the neck is in the profile where normally it should be. And that will help you in that. If you still have a problem, then there are ways to pre-plan it, how to draw your mechanical axis to overcome that problem, if you have the problem. And so there are ways around it. Other problem is the length. And as I said, impingement is easily solvable in theater, but it can be a problem. So length works in two ways. So if you have a deformity like that and you want to correct it, if you do that, it will impinge there. it will not correct in the transverse osteotomy. If it's a dome, it will correct, but if it's a transverse osteotomy, it will impinge. So what you do is, you first lengthen it a bit, and then you correct it. So what happens is that you get a bit of a clearance. Now this, you can do it in theater once you have done your osteotomy, lengthen it a bit, correct it, and then don't forget to compress it again. That's important, because if you leave a gap osteotomy, then the chances of non-union increases. So what you do is you distract it, correct it, and then compress it again and check your alignment again, because you compress, the things can move. So that's important. Then the thing is, so how you do it in theater actually. So one of the things which I have done in the past and I've regretted it is that I didn't leave that space on this rod. So it looks quite sleek when you put in a thing, it finishes at the end, but then you lose all your ability to lengthen the bone on the table. So whenever you plan this, always have a bit of a space on your rod, which will help you lengthen the leg to overcome that problem. The other thing which I learned from Durai is that once you have, before the osteotomy, put in a bit of distraction. And if you do osteotomy in the tension, it actually comes quite easily and easy to know that you have completed the osteotomy. So that's another trick you can use while doing your osteotomy. If it's a dome, it actually rotates quite easily, and this is where you say you should not do, leave no length. But if it is dome, it actually rotates and often comes quite easily without any lengthening. Other problem you will face is that from time to time is that bone quality. And if your segment is small, and what happens is that the stability becomes an issue. And what happens is that it is particularly more relevant if you have a stiff soft tissue, or means somebody had a previous surgeries, then there's a lot of scarring. So that doesn't help. So I'll give you this example. As I always say, I've done all the things which I'm talking to you. So this is a lady with a stress fracture, non-union, and she was clear she doesn't want a frame. And I thought at her age, probably not a bad. And what a reason I wanted to correct the leg was that I was worried that this ankle replacement with an abnormal forces might loosen quickly. And then COVID came, and by the time she was waiting, she fell and she had another fracture there. So now it became a sort of imperative that we have to do it in a case. It helps us because I can put her on the trauma list then. So it is helpful in a way. So this is the case. So this is your pre-correction. I put in the hinge, and I thought I don't have to lengthen it because it'll be kind of opening wedge and I'll be fine. And on the table, actually, it didn't look too bad. When I looked at it on the table, it came out nicely, came straight. But again came the same problem, and then I nailed it. Now, I realized when I finished nailing this is slight under correction, because the leg, when I thought looking straight, is slight varus. I thought we'll probably get away, and we look at it, it is actually a bit of a varus, and it is not a good correction. But I left it because her ankle was parallel to the ground. So the main purpose was that, and I thought it will heal, and it actually didn't. So that looks fine. I left it slightly proud because when we measured it, if I leave it slightly proud, I can put 3 screws at the top. So I thought that will hold, but actually it didn't, because she was osteoporotic and she had a lot of other problems. Age was on her side. So ultimately in 5 months, this became more the procurvatum, it became loose, the nail became prominent, and she is complaining of terrible pain. So we have to take her back to theater and do it. Now, there's a quite simple thing is that we could have done slightly differently. And there's another example in a young patient. Again, this is a lateral compartment osteoarthritis, all I wanted to correct. And on table, it looked fine. And I put the plate on the lateral side submuscular so that with the opening side, it would be held. But again, the issue is that I use the plate, which is not designed for this purpose, is a usual trauma plate as a locking plate, but it is not as stiff. So when I corrected it, it looked fine where I wanted it. And when I finished, actually, it is under-corrected. And so these are the things. So what I should have done is what you need to do. So what I should have done it, in this case, in the previous case, the elderly lady, I should have put in a small plate and then nailed it. That would have been held it much better. The correction would have been held. Or If you're in doubt, do the double plating, because then it will hold it. And so these are a lot of things you will see that you will realize that on table it's obvious. So that's the reason I always suggest take excess number of times until you're really happy. I've talked about hinge, so I won't talk about it, but I'll give you the same example in the sense that how it happened. And I think here, despite all the effort, I think my hinge was not spot on, and this was probably a couple of millimeters. I don't think it will make a lot of difference in long run, but I think it's slightly undercorrected. It could have been slightly better. The other thing is the nail entry point. So when you correct it, you need to pre-plan it, because when you correct it and translate it, you'll find your nail entry point is not the standard nail entry points. And what happens is then, so once you pre-planned, then you know where you're going to put your polar screws, as Paul has quite elegantly showed you. So your reamer and your guide wires are in the line where you want to do it. And this is an oblique plane deformity with translation deformity of the femur, which I did which a fixator assisted. So what happens is that, I've lost that picture somewhere, I don't know, can find it, but there is a pre-planning picture, I promise you. I did pre-plan it. So it went there, and I knew I had to start a bit laterally because of the way the leg is, because it will not, couldn't translate it too much because I have to put in the nail. And so I put in a polar screw, and then everything I did on the lateral side. So it shifted my guide wire, my reamers and nail in the line where I wanted it to be. And so once you put in the fixator, you can pass in a nail, and then when you see it, so if you see it is axis is right, but everything is slightly lateral. And there's a polar screw, which is, you don't have to use the polar screw. If you don't want to leave any implant behind, use a 3.2 DHS guide wire. The downside is if it breaks, you are in a lot more trouble than a screw. So you got to be slightly careful. But the 3.2 guide wire, DHS guide wire, is quite strong. You can put it and use it and then take it out. But then if you show the X-rays, then it doesn't look as sexy because you can't show you put in the polar screw. So whichever way you want to do it. So, but the idea is that you need to ensure that your nail and your path is gone in the way where you intended it to go. Otherwise, you'll end up with the undercorrection. Where you put in the pins, and these are the pictures from Michael Laverick. When I was his fellow about long time ago, these are the pictures in his office. He put these pins to show everybody how to do it. And if you're putting in a nail, you put your pins posteriorly, you can put the nail from here. And again, you put the pin anteriorly, you can put a wire anteriorly, you can do that. And otherwise, you can put it distal enough for the length of the nail. If you're putting a plate, you put it on the opposite side, right? So it's quite easy that way you can do it. And there's the picture of the plate, you can put it on the opposite side. If you're doing a nail in the femur, you put it posteriorly, and then, so these are the two pins posteriorly, and your canal entry point is quite clear. So you have enough space there to put them posteriorly. But the ideal thing is normally, rather than putting in posterior cortex, put it a bit proximal, so you have clear, and you don't want to use the too long of a nail, because otherwise when you correct it, the whole construct becomes slightly unstable. So you put long enough nail long enough, which will give enough stability. And then you put in a plate, then you put in the opposite side, so you can put the plate quite nicely, and you can put some muscular plate or the lateral plate. In LRS, there are challenges, which are that your femur is curved and your fixator is straight. So there's a sandwich clamp you can use. There are devices which you need to use it. So you can do it quite nicely, but you need to be aware and be careful about it. Translation is quite easy. Actually, you undo the clamp which is holding the pins, and you can hold the pins and translate it. And if there is an sagittal plane, there's another clamp which you can use to correct that. And this is, again, so when you compress the osteotomy, so this is important that when you compress the osteotomy, that there's a risk of losing the correction. So especially when the pins are convergent. So you need to be careful about it, check it. Otherwise, you do slight overcorrection. So when you compress it, it comes to neutral where you want it. So to summarize, the most important thing is that you need to be familiar with the system, what you're doing. You should be comfortable what you're doing. If you're not happy, do it on a sawbone. Practice it, see the implants, hold them, see the fixators, see the plates, so that when you are in theater, it's easier. And there are simple steps, but the pre-planning is absolutely crucial. And you can use it on a sawbone. And it is a sequence of the steps and attention to detail which will help you. And actually, most of them actually come quite all right where you want it. But you can't. So when you take informed consent, you always tell patient there's a risk that I may not be able to correct it fully and you have no chance. Though most of them will come, but there's still a risk. Thank you so much.